Hello, my name is Huan Giap. I'm a radiation oncologist, and I've been practice in proton therapy since 1995, residency at Loma Linda. And since then, I have done conventional radiation, but also with a proton center in San Diego. And also lastly is the UC Miami. And with my honor today, I would like to introduce our speaker, Dr. Sina Mossahebi, who is an expert in the use of SDX system in motion management for spot scanning proton therapy. And this is a very difficult topic. And I have learned to know Dr. Mossahebi through interaction at UC Maryland and their expertise in publication and in training people how to use system. Now, Dr. Sina Mossahebi received his Ph.D. in physics and biophysics from the Washington University in St. Louis. This title actually in kinetic calculation of left ventricular chamber stiffness and relaxation. If you know the heart cardiac moving at 60 to 100 to 150 times per second. So you can see the connection to why he's interested in the SDX for proton therapy. Would you think it's too slow? But anyway, so following his PhD, Dr. Mossahebi completed his medical physics residency at the UC Maryland, and then he joined the staff there in 2017. He's been very active in both proton and non-proton, including LDR brachytherapy. He's a director of fellowship program at UC Maryland. He published extensively and gave talk a lot on motion management in proton therapy. He's also very active in WPM, PDCOG, and Moderator committee. And I'm so glad that Dr. Mossahebi gave up his dream at a professional soccer player in his college to turn to his medical physics passion, his second option career, but I think he's doing very well. So with that said, I would like to introduce you Dr. Sina Mossahebi. And for the talks should go to about 40-45 minutes. And I will ask all the people, please submit your question to the chat box, and we will address as much we can at the end at our presentation. Thank you very much.
Thanks, Juan, for introduction. Good morning or good afternoon, evening, everyone. I'm going to talk about SDX system and the use of SDX in motion mitigation using spot scanning proton beam. I've been invited by DYN'R to give this presentation, and I have nothing else to disclose. So at the Maryland Proton Treatment Center, we have variant ProBeam as a 5-room facility. We have 4 gantries and 1 fixed beam. Right now, we use 4 gantry rooms for clinical treatment. And we started in February 2016. Also, we have a Siemens definition edge dual energy CT scanner and also MRI scanner 1.5 Tesla. In one room, we have Vision RT system for surface imaging, and for special treatment, we have SDX breath hold system, and we started March 2018, and so far we treated 120 patients with SDX. And additional to that, we have DTT deep thermal therapy, and we started in 2018 as well, and so far we treated about 50 patients. This is the outline of my talks. I start with the introduction and talking about motion management, and then talking about the SDX system. And then the second part is talking about the commissioning and implementation of the SDX system in the clinic. And the third part is about the dosimetry comparison of the breath hold versus non-breath hold plan. And also I'll look at the reproducibility of the breath hold plan. And at the end, I'll talk about the grid therapy and use of SDX system to treat with grid. So for motion management, usually we use external breathing metrics, and it's useful to predict the tumor motion and reduce the respiratory motion uncertainty. So basically, we can spread the organ at risk. Breath hold technique is one of the techniques that we use for motion management. It mitigates the motion of the target, then we can use the kind of minimize the margin that we use for the treatment, and it can spare the normal tissue. There are different breath hold techniques. One is the non-spirometric using external surrogate, and the other one is the spirometric using the volumetric flow. So in the non-spirometric, we can usually use surface imaging, which is like Vision RT, or real-time position management RPM system from Varian. And for spirometric, there are different devices. The most common one is ABC from Elekta and SDX from DYN'R. So for non-spirometric system, we usually look at the surface motion as kind of we look at the external change. So it can help to reduce the motion and treatment margin. You can have the audio-visual feedback that improves the reproducibility in some of the systems. You can have the gated treatment delivery, and it's a surrogate for internal respiratory motion. And it's also is comfortable for the patient because for example, for Vision RT system, you just get the surface imaging, or for RPM, you have the block on the patient. So it's more comfortable for patient. There's some disadvantages of those systems as external surrogates. It's not looking at the internal motion. And it gives you usually 1D or 2D information of motion. So for RPM system, usually you have 1D information. For surface imaging, it's 2D information. The gating is not compatible for all the treatment delivery system. And the audio-visual feedback is not available for all the systems. There are some problems with mainly for protons. It's like one is the source detector clearance issue. So for example, in the Vision RT system, usually we have a snot and gantry blocking the camera. So we can't get the good information of the surface. And also in some of them, it's position dependent. For if you're using like RPM system, the position of the block can change what you get in the motion management. The spirometry system has other advantages as like similar to the other one, as has reduced the tumor motion and treatment margin. You can have the audio visual feedback. You can have the gated treatment delivery, and it's accurate for internal respiratory motion, and it's easily portable. So compared to Vision RT system that you can have only in one room, or you need to have multiple rooms, so you can transfer patient to the different rooms and use the motion management. This system, you can just move the spirometry system to different rooms as long as you have the system available in the room, so kind of like the connection. The disadvantage is signal drift is uncomfortable for patients. And similar to the other systems, gating is not available for all the treatment delivery. And it still is a surrogate, it's not actual tumor motion. At MPTC, we use SDX system from DYN'R. We started in 2018 as a voluntary breath hold technique, and so far we treated 120 patients. If you look at the SDX system, you have a patient, and then there's a mouthpiece connected to the in the mouth, and then there's a filter, and it's connected to the honeycomb tube, and it goes to the SDX system. Patient has a video glass that can see the breathing pattern and know that at what level of the breath hold should be. When you look at the SDX with a probeam connection, so we have the patient in the room with the SDX system, and the SDX system is connected with an Ethernet cable to the computer, which that computer is connected to the SDX gating module, and that one is connected to probeam gating module, and that controls the beam. For the calibration and calibration check, we do the daily calibration check, and sometimes we do the calibration if we use the different honeycomb tube, or we clean the honeycomb tube. Usually we need to do the calibration. For calibration check, we use the 3-liter calibration syringe, and basically we pump the syringe, and we know the actual volume of the syringe, and we have a tolerance for that, and then we can check the calibration. And if we can pass the calibration, we can perform the actual calibration. This helps to kind of like check the signal drift and kind of like make it better if we see that it's off. Now, about commissioning and the implementation of the SDX system, the goal was checking the effect of breathing interruption and when we deliver the dose. So what we did, we selected 5 different plants with a gating option, and there were SFO and MFO plants. We use, so in some of them we use range shifters, and we did the point dose and planar dose measurement. And we compared that with a 2, 3, and 5 breath hold interruption, and we compared that to 1 without any interruption as a reference. This is the result. So we saw that the maximum percent difference of the point dose measurement was less than 0.4%, and then the lowest gamma passing rate was 97.2% using the 1% 1 millimeter criteria. Now I'm going to talk about the treatment process. So we usually ask patients to do the breath hold practice before coming for the initial sim. And then the first day of when patient comes, we do the training, and then after that we do the CT imaging. So in the instruction, the patient instruction, we do ask patient to do the breath hold and breathe through the spirometer. And then we find the deep inspiration breath hold, and then we reduce that to 75%, and we set that as a breath hold level. So in the training phase, we ask patient to do multiple breath holds. So usually we do 3 to 5 breath holds, and we establish that the deep inspiration breath hold level. Then, as I said, we reduce that to 75%. Usually but in that number, you can change it in the system. It's more comfortable for the patient and it's more reproducible. And then we check with the patient, we do the practice and make sure the patient can hold the breath for enough time. Then after that, we do the initial stimulation. So we do SDX breath hold sim and also normal 4D CT. So for the SDX, the imaging part, it's not connected to the CT scanner, so we have to manually stop the scanning if the patient goes out of the breath hold, and then we do the 4D after that as a backup plan. There are some issues, for example, for head and neck and mid-sternum patient, if you want to use the breath hold, and usually for these patients we use the boss frame with the mask. So the problem is, like, we don't have a place that we put the SDX device. So what we did is we made a kind of a holder that is connected to the CT base table, and we can put the SDX device on that holder. And for treatment planning, it's similar to the normal treatment planning. We do the optimization, and then we use the same computation settings. We do the Monte Carlo dose calculation. And the only difference is we have to, in the race station, we have to turn on the motion synchronization. And for ProBeam system, with the option we have to select is the gating with the external marker. Otherwise, the system cannot understand the other options. Usually we use 1.1 MU per fraction per spot for our ProBeam system. But for SDX and breath hold, sometimes we go to higher MU, like 2 or 3. And then that's how we can reduce the time of the beam delivery. So we use an in-house program to estimate the delivery time of each field. So what we do is we run this program, and then we look at the different MU settings, like 1 MU as a minimum MU or 2 or 3. And then we evaluate the time and also the plant quality. So as you see in this figure, there's not much change in the plant quality, but you can reduce the time of the delivery to about 15 seconds. So basically, patient can hold the breath for 35 seconds, and then in one breath hold, we can deliver the whole field. The other thing we need to pay attention is when we draw the external contour. So we need to include that in the SDX device in our external contour. That helps us to calculate the accurate minimum air gap and also avoid the collision. Now the question is, why do we need a backup plan? So The history is like we had that when we started with SDX 2018, we had the version 2.06. We had some issue with the connectivity, software issue, and then we had only one SDX device in one room. So if we had a problem with SDX device, or if there was a problem with the in the treatment room, we couldn't treat the patient. So we decided to have a backup plan for the backup plan. And so then later we upgraded us to version 3, and right now we have the version 3.12. And so we have much less software issue. And then also we purchased another SDX device. So now we have 2 rooms that, if we have a problem with the room, we can still use another room for the treatment. And recently, because of COVID, we decided to do again backup plan. And then if the patient comes with a symptom, so we decide to go with the 4D plan, not using SDX. And so we create after the scan, we created treatment plans on the SDX plan and the 4D. And we evaluate the plan with the physicist and physician. And for the treatment, we use KV and CBCT for IGRT. So at the program system, we need to have at least 35 seconds breath hold, and we can do the cone beam CT. So usually when we do the practice with patient, we make sure that patient can hold the breath for at least 25 to 30 seconds, and then we ask the patient to do the practice at home before the first treatment. And then for the treatment, we use an automatic gating module, and which is active and then connected to the program system. So during the treatment for the IGRT, again, is similar to CT. We have to stop the imaging manually if the patient goes out of the breath hold level, but the treatment is completely automatic. So we usually start the beam and then wait for the patient to go to the breath hold. As soon as patient gets to the breath hold, the beam runs, and then as soon as patient goes out of the breath hold, it stops automatically. And for monitoring, then we use the weekly QACT. So we look at the tumor response and also anatomical changes. And also we want to make sure that the breath hold plan is still valid for the treatment. So this is the workflow we have. So we started, we had the 150 patient referral for the breath hold treatment. From those 128 patients went under the CT simulation, 22 because they couldn't do the breath hold. And so far we treated 120 patients with SDX. So as I said, 22 excluded because they couldn't hold the breath more than 25 seconds. And this is the patient numbers at different sites. And from that 128 patients, we treated 120 patients. 2 of them were proton greed. And 7 patients, the physician decided to go with the 4D plan because of the coverage and the normal tissue sparing. And 1 patient couldn't tolerate the breath hold in the middle of treatment, and we switched to the 4D plan. This is the number of patients we treated with the conventional fractionation and the hypofractionation. So we treated 53 with the conventional 1.8 or 2 gray per fraction, and for hypofraction, we treated 67 patients. And for hypofractionation, we have the different dose levels for fraction dose, and we treated 2 with grade, which is 15 gray per fraction. In summary of part 1, we can use SDX system for any movement tumor due to the respiratory motion, and patient should be able to hold the breath for 25 seconds. And the smaller the target, it's easier to do the breath hold and implement the procedure. And it's good to ask patient to do the practice before the initial SIM treatment. We we have 2 plans for SDX plan and then normal plan as a backup, and we use KV and CBCT for image guidance, and we do weekly QACT to look at the tumor response. So the next part is talking about the breath hold versus non-breath hold. So as I said, the breath hold technique is good for minimizing target margin and improving the normal tissue sparing. So as I said, that we have 2 plans for number of patients. So we have SDX and 4D plan. And in this part, I want to look at the benefit of breath hold technique. So we look at the 61 patients with both SDX plan and 4D plan, and breath hold level was 75% of the deep inspiration breath hold. And we look at the mean dose of the OAR and also max dose of some of the OARs and also the DVH. So this is the look at the target volume. So CTV1 and CTV2, the initial NSFP. And as you see, we can have about a 28% reduction in the average volume of the tumor. So this part is like you look at the max dose of the OAR. So for different organs, small bowel, large bowel, heart, and spinal cord, it's about like a 15 to 30% reduction in the dose, max dose to OAR. Similarly, for lung, B20, and liver mean, so we have about 20 to 25% reduction in the dose, and also for mean OAR dose of the stomach, kidney, esophagus, and heart, again, we have about 20 to 30% reduction in the dose to the OAR. Then I look at the different groups. So I look at the liver group, 25 patients, and mediastinum group of 17 patients. And again, we see the similar pattern. So we have a less target volume, and we can reduce the dose to OAR for liver, stomach, kidney, heart, and esophagus. Similarly, for the mediastinum and lung group, 17 patients, we have like about 20% reduction of the target volume, and we can spare OAR. And as you see, as a mean OAR dose is about 10 to 50% reduction, and max OAR is about 5 to 20% reduction. In summary, breath hold plan can significantly reduce the treatment target volume, so about like 20 to 25% reduction. And you can spread the OAR, as you see, as like about 20 to 25% reduction in the dose to OAR. And we saw like a mean dose about 10 to 50% and max at about 5 to 40%, depends on the OAR location and tumor location. So the next part is talking about the reproducible breath hold plan. So it's good to minimize the target margin, but we want to see if we can continue with that breath hold plan in the whole course of the treatment. So we had the QACT and weekly QACT. So, and we look at the reproducible breath hold plan using the QACT. What we do, we use the 5-millimeter robust evaluation of the SDX plans. And then this is, we use 30 patients and then 62 QACT. And we look at the reproducible breath hold plan. So at MPTC, we have, when we have a QACT, we look at the target coverage. And if we have a target V95 decrease more than 5%, or we have a significant change in the dose to the OARs, we repeat the QACT or do the replan. So to evaluate the breath hold plan, we look at the DVH variation of the QACT plan. So we use the same plan, we calculate that plan on the QACT, and then we look at the percent difference for target and also absolute dose difference for OARs. And we look at the error window, which is covering the 95% percentile of the variation. So this is the CTV1 volume. So, and then as you see, the error window, which is the 95 percentile variation, is about 8.6% for CTV1 and 4.5% for CTV2. Then we look at the target coverage, V95, D95, and mean dose. For all of them, we have the variation less than 5%. For maximum and minimum dose to the target, so we have a larger variation at the error window of 5.7% for CTV1 and 18% for CTV2. And for mean dose and max dose and lung and liver dose for looking at error window for mean dose for heart, esophagus, stomach, and kidney, we have less than like 1.5 grade change. For max dose, we have a larger variation. It's about less than 5 grade. And then for lung and liver, still is the variation is comparable to other organs, despite the kind of there are more affected by the motion. So we have an error window of about 1 gray for liver mean and 3.2% for long V20. Based on our data, we had 4 replants due to the change in the target coverage and OIR dose, and mostly because of the anatomical changes. In summary, we look at the 30 patients, and we had only 4 replants due to the tumor volume or anatomical changes. And we see that the Brett Holt technique can manage the respiratory motion. And in the absence of anatomical changes, the coverage and OIR dose were reproducible within the clinical acceptable margins. Using 5-minute robust evaluation helps us to have a good reproducible plan. And we saw a small variation in the target coverage and larger variation for minimum and maximum dose for both OIR and target. The last part, I'm going to talk about grid therapy and then using SDX with grid. So grid started in 1900 and it's been in the clinic since 1930s. And it's used to treat the bulky malignant tumors, and we are planning to spread the OIR. What it does is provides a distinct spatial dose distribution, and usually the fraction dose is like a 10 to 20 gray and is a 1 fraction. And after that, we have the normal fractionation. In the normal treatment, we have the homogeneous, the plan is to have a homogeneous dose to the tumor. So as you see here, you have your goal is to have a prescription dose to whole tumor. In the grid, we have the distinct spatial dose distribution. So we have the peaks and valley. So using proton, we can have a better dose conformality, and also we can use the intensity modulation. So we can reduce the entrance and exit dose and also spare the OIR. So in the photon treatment, in the grid, we use MLC and JAWS. Historically, we were using blocks, and nowadays we use MLC and JAWS to generate the grid pattern. In proton and pencil beam, we can modulate the spot position, energy, and MU to create a grid pattern. Now, if you look at the proton grid versus photon grid, there are some advantages with the proton grid. As you see, there's less entrance dose compared to the photon grid. Sometimes in the photon grid, you can have a maximum dose outside the target. Here, we have the maximum dose in the proton grid inside the target. And also, you have no exit dose compared to the photon grid plan. So the fraction dose is 15 gray in 1 fraction. We usually use the target volume of GTV, and you can use a proton or photon. For imaging, we use KV and CBCT for and that's single fraction to assess the soft tissue and as well as the any other structure. For planning part, we have the GTV is drawn by the physician. Then we create a planning GTV, which we kind of contract the GTV to kind of avoid end ranging, avoid any inhomogeneous composition like bone and air. And also we aim to have the longest path length, the longest cylinder inside the tumor. And if it can have at least 4 cm depth, then we don't need to use the range shifter. Otherwise, we need to use range shifter. And then we use the script and ray station to create a cylinder. So basically, we create a virtual target, these cylinders, and usually the diameter is like 3 millimeter, and we use a spacing 2.1 to 2.4, depends on the target location, depth, and energy we use. And then we call that the planning GTV, and then we crop that planning GTV from the cylinder inside the planning GTV, and then we use that as a virtual target to create the plan. Then we do the same thing. We use the same computational settings and the optimization, and we do the Monte Carlo dose calculation. The difference with the normal plan, we use 0.15 cm compared to 0.25 cm for the grid size, and then we removed all the spots outside the cylinder or outside the target. We don't use any robust optimization, and after that, physicists and physician evaluate the plan. So the goal for the crate is we want to have the maximum dose about 15 gray, so we accept up to 17 gray. The valley we are aiming to have like less than 5 gray, and the mean dose to the actual GTV we want to have about 4 to 5 gray, and then with the line dose profile or the peak to valley ratio, we want to have more than 3, and then the range we use usually is 3 to 8. This is one plan that we did the grade, so we were able to meet the goals. And as you see, the energy we used was from 70 to 127 MeV. We used 22 energy layers and 784 spots. And then the total MeV was 120,000, and the minimum spot we used to generate the plan was 5. At the end, we create contours for the different isodose lines. We usually do 4, 8, 12, and 15 gray isodose lines, and we export it. And then it's good to evaluate the plan when we set up the patient and after the IGRT. So the treatment, we do CBCT imaging, and the physicists and physician evaluate the image carefully. There shouldn't be any volume change or depth dose change. And we also look at there's no weight loss. So these are some examples if there is a change in the volume. So in this plan, GTV was the red one. So if in the treatment, we notice that there is a shrinkage in the target. So now we have this orange as our treatment target. So now we have those to the normal tissue because now they have a smaller target. So the other one is look at the depth change and weight loss. So on the right, if we have the weight loss, and then we have a kind of like a shallower depth for the target. So in the initial plan, we have the isodose line, stopping at the end of the target. Now we have less kind of tissue in front of the beam, so we don't have that isodose line distribution. Now we stop in the normal tissue, and we have those to a normal tissue. That's why it's good to carefully evaluate the image and make sure there's no volume or depth change or there's no weight loss. There's another concern is like smaller air gaps, especially when we use the range shifter. It's better to use the smaller air gap so we can have a smaller spot size, but it can help us like to spare the normal tissue, and then in the crate we can have less GTV mean dose by having like a smaller air gap when we use range shifter. But the only thing is like we need to make sure that there's no collision, especially when you use SDX. So in this case, we had a patient that we were using SDX and range shifter, and we wanted to have a smaller air gap to have better grid pattern. So we had to test and make sure there's no collision with SDX. As I said, we use SDX for 2 plans. So the first patient was a 72-year-old male. We had the left abdominal mass, and it was our first SDX grade patient. And we used the gantry 90 degree, and because we were not using range shifter, so snot was at 42 cm. And the total MU was 32,000, and we were able to deliver the plan in 1 breath hold in 55 seconds. So as you see, this is the DVH of the plan. We were able to have a good coverage on the cylinders, and then we met our goals for the GTV grade and also the cylinders, and we were able to meet our goals for the OARs. And as you see, we have less dose to spleen, stomach, left kidney, large bowel, and skin. The second one is the 73-year-old liver case. In this case, because of the motion, we use SDX again. And here, because the location of the tumor is in the shallow region, so we had to use the range shifter. So we used range shifter, and the snot position was at 12.3 cm. The air gap we used about 7 cm. And we were able to create a really good grid pattern. And we treated patient and delivered the whole field in 48 seconds, and patient could hold the breath in that field delivery. Again, this is the DVH for GTV. The maximum dose was 15 gray, and then we have a average about 4.8 gray, and the cylinder, the average was 14.5 gray. And then there's not much dose to stomach, large bowel, and heart. In summary, in the treatment planning, we can create a planning instruction, and then using the script, you can create a cylinder, and then you can crop that cylinder within that planning structure. And then after that, you can do the optimization and use the race station Monte Carlo dose calculation to do the final dose calculation. And the only difference is we use the calculation grid of 1.5 millimeter. And for cases that we have emotion through the breathing, we can use the breath hold system or SDX, and then it's better to deliver the whole field in one breath hold. For treatment, the IGRT, we use CBCT, and it's good to evaluate the image before the treatment to see there's no volume or depth change, and there's no weight loss. I would like to acknowledge my team, and also would be happy to answer any questions.
Awesome. That was a great presentation. Yeah. So so we're looking for questions from the audience. Please put your question in the chat box. I will try to address the question. So I have a few questions for you, Sina. So you mentioned that the threshold used is 75%. Is that all for all patients, or is that for lung patient only? The reason I'm asking that because when for lung or thymus patient, we like to use a patient have deep innovation as much as possible, 75%. But for liver or pancreas, to make person more comfortable and also more reducible abdominal organ, we try to keep the threshold lower, maybe 30, 40, 50%. I want your opinion on that one.
Yeah, that's true. It depends on the patient. So for most of the cases, we use 75%, and then most of those patients that I presented, they were able to hold the breath in that 75%. You know, in some cases we had to reduce it, go to lower if they were not able to do the breath hold in that 75%. And in some cases we go to higher, like 80% or 85%, depends on the location of the OAR. So, but you know, it depends on the patient. You can go to lower breath hold level.
Okay, yeah, because for liver and pancreas, I think having lower, less abdominal organ is more reducible for us, as much as the patient can hold the breath. Yeah, so yeah. Another question is, you know, we start using this system when open at our center 2014 in San Diego. They call Script Proton Therapy. Now it's called California Proton Center. And at first, we use this for lung and we don't use for liver. And we learned that for the patient compliant, first they have the patient see the system first because it's something new. And also I send the patient home with the nose clip and the mouthpiece and ask them to practice at home with the stopwatch. And I find that it's helped patient compliant because they have the thing at home, they play it for a few days. So you know what it's like, you know, with the mouthpiece, like snorkeling mouthpiece and then the nose clip. And I find that help a lot. What do you think about it?
Yeah, I agree. We did for a couple of patients, you know, after initial simulation, and we thought that, you know, it's good for them to practice with the nose clip and the mouthpiece. So we asked them to, you know, use that one and then do the practice. So it's good if you can do that. So, but it's like, you know, you have, you know, to give this before the initial simulation to, you know, they can practice. Usually at the initial simulation, we have like maybe an hour for the training. So in that time, they practice enough to kind of like get comfortable with the breath hold.
Yeah, another thing I also comment on the system that we use it in 2014, but over the years, over several years, I think SDX have done a great job in improving the software and hardware. And the big thing is the auto-gating module, because we remember when we first have it, we have to have therapists watching the screen and put a pause. And for the variant pro beam, it took about 10, 12 seconds for this when you put the button into the machine respond. So having that auto-gating module, I think it's a great thing, and the software definitely much better. You are using that. What do you think about that at Maryland?
Yeah, at Maryland, so we had a kind of similar problem at the beginning. So when we were using the version 2.06, so we had some problem with the software, but it's been good now because we are using the recent version 3.12. So it's like we barely have any issue with the software or SDX, and it's kind of like especially with the probing system and gating module, is really easy for the therapist because they don't need to worry about like treatment, like when they do deliver the plan, because what they do is like they request the beam, and when they get the beam, they turn beam on. There's no delivery until the patient goes to the breath hole. As soon as patient gets to the breath hole, after like a second or two, the beam is delivering, and then when it's going out, stops automatically. So the gating module helps a lot compared to some centers. They don't have the gating module, or it's like it's not compatible with the SDX system. So what they do, they have to manually stop the beam. So that's kind of like
I think the human one. What a nice thing about have SDX as a single product is that they respond to the customer, and they don't have one product, so they work on it all the time. So have a nice have all the update. And so another thing I have question for you is question we have is with the two system you have right now, you find that the workflow work out perfectly, and you can use it in two different rooms, and with a simulation, is that adequate? And
right now, yes, we have. So we have one system, one of the SDX system usually at the CT simulation, and the other one in one of the room that our treatment room 2. And most of our SDX patients we treat that in tier 2. But if there's a problem with that room, or we have like many SDX patients and we have to do kind of like a same time treatment, so we use the other room as a kind of backup. So we moved our SDX system from CT simulation to TR4 and then treat patients. So if you have more SDX system, it's better, but it's like I feel like for some place like ours, that like at least we need to have two SDX system.
Yeah, we have a question from the audience. You mentioned one disadvantage of spirometric system is the baseline drift. What reason make that drift, on your opinion?
So that's known for a spirometric system. There's a drift in the signal. So that's why I think we do the everyday calibration check and the calibration. So this is kind of like the disadvantage of the spirometric system. But the good thing is like, the system forces you to do the calibration check. And if there's off, then you can calibrate and then set a new baseline.
Yeah, another thing I also learned is the real from the patient internal anatomy change day by day, right? So we use, because for each patient, we do one CBCT, right? And every day, so we use that to analyze the internal rift. Let's say we treat the liver, and we look at the dome liver, for example, and we use that CBCT to assess how much rift patient have internally. Yeah, so that's how in adjusting our plan and our margin, if we need to do a data plan or recent patient, we have that data. You use that CBCT on your system there also? Yeah.
Yes.
Okay.
Yeah, so we set up the patient with KV, and then for both KV and CBCT, we ask patient to go to the breath hole. And then for CBCT, because of the, in program system, it takes for kind of like a half scan, like, or the kind of like going to the head mode, it takes 35 seconds. So we ask patient to hold the breath at least for 35 seconds, and we do the CBCT and then evaluate. And if we need to do any adjustment after that, so we do KV and verify that one.
Yeah. Okay. Another question. Let's see. There is a question here. Have you combined the SDX with SGRT, surface guided radiation therapy, like CRAT or virginality? What is your opinion on that?
We haven't combined them. We did the kind of evaluated SDX versus Vision RT and RPM system. There was a paper a long time ago in WashU that they showed that like the spirometric system is doing better compared to surface imaging or RPM system. But we look at them, and then if we saw that like there's a better correlation if you use a surface imaging and SDX system. So you know, it's kind of like you need to do some extra kind of like evaluation, but we look at the correlation between the SDX and the vision RT, and we saw a good correlation. But we haven't tested on the patient to look at, you know, if it's going to be kind of we can replace like vision RT or surface imaging. The main reason is like for at least in our room in our center, the camera that we have on the ceiling is kind of far from the patient. And when we have a range shifter and we move the snot or we have a big gantry, it can block the camera. So vision RT is not going to work well if we want to, you know, we use range shifter or move the snot.
Do you know the vision RT or CRAD have the automatic module that connect to the probeam system?
No, right now we don't use vision RT for gating at all. We use it for breast patient just for setup.
Yeah, so that's what I think most of SGRT, CRAD, or vision RT, mostly for setup patient, particularly breast, just, you know, set up any patient. And they also have some data, I think they have for, I know for non-proton and maybe a certain system, but I'm not sure for probeam, they have a direct module or a lot of experience with the patient for motion management. Yeah. And so that's another issue. So it'd be good to have somebody that you both combine to see it make a difference or not, or just don't need them. I know that for the SDX, they have the most experience, most user for the probeam system, and I'm working on a new system, new proton center. We try to get a cost request, and I find out the other system, the SGR system, costs 3 times or 4 times more than the SDX system. So how to justify?
And the other problem is for some of these systems, like, you know, vision RT, at least in our center. So if, like, you know, we have it in the treatment room 3, if the room has a problem and we have that, like, you know, system in that room only, you can move it to other room. So SDX system, you can just, you know, move it to another room and use the, you know, connect to the computer and then start the treatment. As long as you set up everything, you know, in the software in the computer, it's easy to just move it, because we had some issues, like we had to work on the gantries to, you know, for different rooms, and we had, like, you know, we were able to move it to another room, like, you know, start, like, you know, all the rooms. We have the gating module ready, so we can just move the gating, SDX gating and SDX device, and then start the treatment.
Yeah, because I look at SDX and the SGRT somewhat different. They may have some overlap, but you think of SGRT almost look at patient active control, right? Patient had to be visible area, but the SDX almost like an internal fixation. You think of this way: you take patient inhale, hold the breath, right? Control the internal organ, just the lung and the upper abdomen area. So somewhat the internal fixation, but the patient have controlled it because they see through the goggle. They have some visual feedback on how to do things, and a lot of patients like it. I have some patients that they use the SDX, and when we had a reaction breakdown and need some service, they don't want to get treatment. They say they want to make sure their treatment are in the zone, what they call that. So patients have that comfort that they can see the thing and they control their internal organ somehow. So I thought that covered nice. Yeah.
Yeah, and also, so the new version of SDX, they have that moon feature. So you know, some patients, they like to see the bar and then go to that breath hold, but some patients, you know, they're not, you know, kind of like comfortable, or they don't understand that well. But that moon version is like, and if they say, okay, that moon is kind of, you know, showing your breathing pattern, just move it to that, you know, circle and then hold it there. They understand better. So right now, for most of the patients, we use that moon feature.
Okay. Let me see what else. Let me see a question. What did RID stand for? One question here. GRID.
Grid? It's like just a grid pattern. It's kind of like a grid. Like, you know, it doesn't stand for anything. But there's a treatment that, you know, you have kind of like a distinct spatial dose distribution. So it's kind of like you have a high dose and low dose kind of. That's a grid pattern. You know, it's kind of like
I did almost try to duplicate like the HDR boost, something like this.
Yeah, it's kind of similar to that, but the benefit of grid is like because you have a low dose in the surface, so you can spare the skin much more compared to giving uniform dose, high dose. So they've shown that it's much better in terms of like delivering like 15 gray. Using the grid pattern versus the 15 gray, like uniform dose.
Very interesting. Yeah. So let me see. I had more questions from the audience. Great, interesting. I learned a lot. Yes. Thank you for sharing all this information. Let me see. All right. I think we're almost to the time
there was
limit.
One question about like the drifting. So there's another thing is like at least for SDX when we because of COVID we cleaned the honeycomb tube, that metal piece, every night. So and we have the multiple of them. So if we use different ones, so it's kind of you have different baseline because they have like different kind of structure, different hole, maybe size or location. So that's why sometimes we have to do the calibration when we do the cleaning or change the tube. So this is another thing that you set another baseline based on when you do the changes.
Yeah, one comment, one question. Maybe this is made for SDX people. Do you ever think that the patient compliance will be better if instead of having breathing room air, then we have oxygen into that machine, so you can have more oxygen in the lung? What do you think?
Is it for me or SDX people?
I just ask your opinion, but I think the question direct to the SDX. Patient having oxygen when they inhale, that's why they have more, high oxygen concentration in the lung.
If they can design that, like, instead of this mouthpiece, they can have a kind of oxygen mask type. It's more comfortable for patients. So right now, because it's not, I don't know if like, people, do the practice themselves before implementing this, but it's not really comfortable. So if they change the design that, they use the kind of oxygen mask type, for the patient, I know it's kind of then it's not really easy because people have different, like, size of faces, and then like, it's not really easy, but that one can help a lot. It's much more comfortable for patient.
I think I saw it at an exhibit a couple of years ago. Annabelle, any comment on that? I think you have that version somewhere.
Yes, so we are working about implementing the mask in the US. We have a few centers, especially one in the south of France, that is using masks. It still has to be tested here. But this is something we're definitely looking at because the oxygen topping is not new. We've had several conversations with different centers.
All right, so I think that'll be much more easy for the patient, and we have more person compliant. All right, so I think we're approaching our time limit. Unless any other question, I would like to thank you, Dr. Sina Mossahebi, for this excellent talk. And anyways, if you have any more questions, please email to the host, Annabelle, and then we can try to address it later on. But thank you, everyone.